to this important meeting. My task today is to give you some insights into the transcatheter aortic valve implantation in degenerated surgical aortic valves with aortic root replacement. TAVI, within the failed bioprosthetic surgical aortic valves, has become an established procedure, currently approved for patients at high risk for repeat aortic valve intervention. Although it is less invasive than surgical reoperation, there are several challenges of valve-in-valve treatment. Here are the main etiologies for failure of surgical bioprosthetic heart valves, namely structural valve deterioration, non-structural valve dysfunction, paravalvular regurgitation, prosthesis patient mismatch, valve thrombosis, or endocarditis. Several definitions have been proposed for the structural valve deterioration. This one is from the EAPCI, endorsed by ESC and EACTS. But the most recent one is the WARC3 classification, which goes into two types of transcatheter heart valve durability, namely bioprosthetic valve deterioration and bioprosthetic valve failure. Shown here, there are 4 stages of bioprosthetic valve deterioration. Stage 1 is with morphologic changes, with slight or no hemodynamic changes. In stage 2, there are moderate hemodynamic changes, and in stage 3, there are severe hemodynamic changes. And the bioprosthetic valve failure goes from the clinical sequela to valve-related death. When could we decide for TAVI, valve-in-valve TAVI, or redo surgical aortic valve replacement? There are factors related to the patient. For example, if the patient is of very high or extreme surgical risk, or very old, over age of 80, then we prefer TAVI to SAVR, redo SAVR. Of course, patient preference is always very important to be considered. There are factors related to the surgical valve. As I mentioned, the patient prosthesis mismatch is very important, and if we think that it is the risk is high, then we prefer redo surgical AVR instead of TAVI. And if the severe patient prosthesis mismatch is present or is foreseen, and the balloon fracture is not feasible or at high risk, then we prefer surgical replacement. And comes the anatomic features, particularly the coronary anatomy, and also the aortic root structure is important. If it is too calcified, then we prefer valve-in-valve TAVI. The pre-procedural planning is very important and critical. And there are two important issues. The first is the evaluation of types and dimensions of the surgical valves, which is related to the patient prosthesis mismatch. And there are measures to reduce the risk of PPM, like bioprosthetic valve fracturing. And the second issue is the evaluation of the coronary obstruction risk in valve-in-valve TAVI. And with this, actually, the procedural imaging is very critical. Rigorous analysis of echocardiographic imaging should be performed pre-procedure, and CT imaging is essential. CT imaging helps us to show where the valve should be crossed with high reproducibility, simulating fluoroscopic waves, and helps us to assess the coronary implantation sites, and also helps us to assess the aortic graft dimensions at the ascending aorta level, and also helps us to detect the aneurysms or aortic arch and descending aorta dissection. The key in the procedure, the key step, is the visualization of the sewing ring as a landmark. Angiography will be required if visualization is poor. The trans-aortic valve sighting should be, as with normal practice, with sewing ring envisioned as virtual annulus. Deployment should be under rapid ventricular pacing to avoid valve embolization with smooth and slow valve deployment and release. Valve stability may be assessed on post-deployment with contrast angiography. Concurrent coronary angiography is also useful in the assessment of coronary anatomy and early coronary obstruction. Choice and sizing of transaortic valve should be dependent on the analysis of coronary interaction, sewing ring size, and leaflet and sewing ring anchorage. Both balloon expandable valves and self-expanding valves do have their own advantages and disadvantages. For example, balloon expandable valves are better for better precision in valve sizing by allowing slight over and under inflation and feature reaccessing of coronary arteries if required. And in self-expanding expanding valves, we have the opportunity of commissural alignment. As you know, balloon expandable valves are in valve leaflets, and self-expanding expanding valves do have a supra valvular structure. Here I show you how we measure the dimension of the surgical valve. We usually measure from the external side of the stent, but we have to be aware of the true internal diameter of the surgical aortic valve, which depends on the type of the surgical valve. For example, as shown at in the slide, at the section A, at a porcine valve, you see the true ID is at least 2 millimeters less than the stent ID. But on the right, at the C section, you see the pericardial valve, with leaflets sutured outside the stent frame, and true ID is the same as the stent ID. There are factors impacting the coronary access after transaortic valve in surgical aortic valve, and there are anatomical and device-related factors. The sinus height, sinus width, coronary height are all important. Of course, the device type uh, and the position of the surgical valve within the aortic root is also critical, and the risk of coronary obstruction is determined by the interaction between the aortic root anatomy and the type of surgical heart valve. Shown here, you see in the middle, the narrow coronary sinuses have a higher risk of coronary obstruction. There are several measures to really prevent or to avoid the risk of coronary obstruction. One of them is the chimney approach. The other one is basilica, intentional laceration of the aortic leaflet. You see there are several algorithms to direct the basilica procedure. This is a very important bunch of data uh, published 3 years ago. This is a meta-analysis, includes 16,000 patients comparing valve-involved transcatheter aortic valve replacement and redo surgical aortic valve replacement. Shown here, you see the 30-day mortality and was better, and it was associated with less major bleeding, the transcatheter aortic valve replacement, but the patient prosthesis mismatch was very severe. You see the hazard ratio is nearly 5. And the hospital stay is very short. It's in transcatheter aortic valve replacement as compared to the surgical aortic valve replacement. Now, Bentall operation is a complicated operation. Shown here, you see there is the replacement of the aortic root and also the re-anastomosis of the coronary arteries on top of the aortic valve replacement. Therefore, the valve-in-valve TAVR for degenerated aortic valves with Bentall prosthesis, although offers less invasive option, particularly in high-risk patients, however, the presence of Bentall prosthesis adds some challenges, including anatomical complexity, which is expected, and including difficulties in coronary artery access and prosthesis selection and positioning is also critical. We need to use the appropriate size and position the new valve to reduce the risk of PVL and valve embolization and coronary obstruction. Imaging and planning really has some more details and is more complicated. There are also technical challenges because of the rigid, very rigid structure of the Bentall graft. Here, I would like to share with you a case from our series. And this is a 72-year-old male admitted with a complaint of shortness of breath, exertional chest pain, and palpitation. And on physical examination, his blood pressure was 150 over 50 millimeters of mercury, and there was a severe systolic murmur in the aortic area with mild peritoneal edema. His past medical history revealed a mental operation 10 years ago, and there was at that time during at the preoperative diagnostic angiography there was a slight coronary lesions, and he was in sinus rhythm. Echocardiography showed a severe aortic stenosis with some aortic regurgitation. Here is the CT findings of the patient. As shown here, the coronaries were open and with some lesions at the LAD, but the coronary ostia height were really reasonable for a self-expandable device. This is the coronary angiography that we performed during the procedure. Shown here, you see a very critical LAD diagonal bifurcation lesion. We stented first, and then we implanted the Medtronic Evolut R self-expandable valve to the aortic position with no aortic regurgitation at the end with a post-procedure aortic valve gradient of 18 millimeters of mercury. Well, valve-in-valve TAVI in degenerated aortic valve with ventral prosthesis is not a frequent procedure. This is the report published in July 2024. There are only 6 case series and 3 in one report, total 8 cases, which were reported to be performed successfully in the ventral prosthesis. This slide summarizes what we do for an aortic, transaortic valve-in-valve for the surgical degenerated valve, from patient selection to pre-procedure planning, and then during the procedure, the selection of the valve and prevention of the coronary obstruction with several procedures. You see how the valve-in-valve decision-making has been affected. Well, there are still some unresolved questions regarding transaortic valve-in-valve and in the surgical aortic valve, including safeguarding against coronary obstruction. This is not completely been solved yet. Of course, stroke prevention and also the post-procedural care considerations like antiplatelet versus anticoagulant treatment. In summary, dear Chairman, ladies and gentlemen, valve-in-valve TAVR is a valuable option in the treatment of degenerated aortic prosthesis, including ventral prosthesis, particularly in patients with high operative risk due to a lower incidence of perioperative complications and better early survival compared with Bidu SAVR. In contrast, Bidu SAVR might still be the preferable option in young patients with low surgical risk and long life expectancy particularly with small bioprosthetic valves, to avoid the long-term complications of elevated residual aortic transvalvular gradients due to the patient prosthesis mismatch. A randomized trial is required to generate more conclusive results about the comparison between valve-in-valve TAVR and redo SAVR. I thank you for your attention.